Associate Professor in the Departments of Global Health and Infectious Disease at the University of Washington. And I'm going to give a talk regarding the initial management of the HIV-infected patient who also has active tuberculosis. Now I'm going to start this talk off by presenting a case that I think will help us to think through the actual management decisions that often confront us when dealing with this issue of HIV and tuberculosis co-infection. So for our case, and this is based on an actual case, we have a 40-year-old man who presents to the emergency department with a 2-month history of fever, night sweats, weight loss, and cough. His vital signs are remarkable for an elevated respiratory rate of 20. His oxygen saturation is 93% on room air. Physical exam is remarkable for anorexia and for some crackles heard in the right lung field. Past medical history, remarkable only for HIV disease. His last known CD4 count was 220 cells per millimeter cubed, but that was 3 years ago, at which time his HIV viral load was 67,000 copies per milliliter. He is not on antiretroviral therapy. In fact, he is on no medications whatsoever. In terms of his social history, he immigrated from Ethiopia 3 years ago, but was lost to follow-up after his first healthcare encounter, at which time the above laboratory studies were drawn. So in this patient, I'd encourage you to think briefly about what conditions you might be worried about and what tests would you order. And I think that our initial tests would, at a minimum, include a chest x-ray, a sputum smear, and certain routine blood labs such as complete blood count and a metabolic panel. And we get those results back. The chest x-ray is shown in front of you. It's remarkable for some opacification in the right upper lung field and perhaps some opacification in the right lower or middle lung fields as well. His white count is low at 2.3. Hemoglobin is slightly low as well, as are the platelets. And you are able to obtain a Zeal-Nelson stain of the sputum, and you see acid-fast bacilli in the sputum. So all of this is highly suggestive of tuberculosis, of course. He's admitted with respiratory precautions and supplemental oxygen. Your sputum cultures and sensitivities are pending. So at this point, what is the next appropriate management step? And I put out a few examples here. Would it be to, for example, start anti-tuberculosis therapy immediately with a typical regimen of rifampin, isoniazid, pyrazinamide, and ethambutol? Would it be to start antiretroviral therapy for his HIV disease and start the tuberculosis therapy if and when TB is confirmed by a molecular probe assay with sensitivity analysis? Would the next step be to start prophylaxis against pneumocystis pneumonia, again, deferring the initiation of tuberculosis therapy until we confirm the diagnosis with the molecular probe assay and we have resistance sensitivity analysis? Or would it be to start steroids in order to prevent the possibility of an immune reconstitution inflammatory syndrome once we start treatment for the HIV and tuberculosis? Well, my take is that the first step really should be to start anti-tuberculosis therapy. In cases where you have a patient who's initially diagnosed with both HIV disease and active TB, the first priority is to treat the tuberculosis because this is the most immediate threat to his health. Indeed, tuberculosis is the leading cause of death of people with HIV worldwide. And so we focus on the immediate threat first, start treatment with tuberculosis therapy. The potential of having a resistant strain of TB is important, but of course the regimen can be modified subsequently if our tests suggest that there is resistance to any one of these tuberculosis agents. So we start anti-tuberculosis therapy with a standard regimen of rifampin, isoniazid, pyrazinamide, and ethambutol. Additional laboratory studies return the next day. Our molecular assay confirms Mycobacterium tuberculosis. Fortunately, there is no evidence of resistance to any standard tuberculosis drugs. His absolute CD4 count is now 23, or 4%, and his HIV viral load is 189,000 copies per milliliter. I want us to think now about what should be done regarding prophylaxis against pneumocystis pneumonia, because this patient, by virtue of having such a low CD4 count and by virtue of having tuberculosis, is now an appropriate candidate for prophylaxis against PCP. So, is it best to defer PCP prophylaxis until he's completed at least the first 2 months of TB therapy? Should we start PCP prophylaxis now using trimethoprim sulfamethoxazole, also known as Bactrim or Septra? Should we instead start PCP prophylaxis with an alternative drug such as atovaquone or aerosolized pentamidine? Now, I would say that there is no undisputed clear answer to this question, but my preference would be actually to treat with atovaquone. The reason I suggest using atovaquone as PCP prophylaxis instead of the standard trimethoprim sulfamethoxazole is that there's a much lower risk of the patient developing a rash from atovaquone than there is with trimethoprim sulfamethoxazole. While trimethoprim sulfamethoxazole is our standard regimen for PCP prophylaxis, and with good reason, it is associated with a high rate of rash in patients with HIV disease. And in this patient, we are starting tuberculosis therapy at the same time, and there is a risk of rash from the tuberculosis medications as well. So if we were to start trimethoprim sulfamethoxazole at the same time as at essentially the same time as we are starting tuberculosis therapy, and the patient were to develop a rash, we would have a lot of difficulty sorting out which agent was responsible. So for the sake of simplification and avoiding that dilemma, I would propose we use atovaquone instead for PCP prophylaxis, at least initially. The next question that comes up is, when should antiretroviral therapy for this patient's HIV be started? Should we start treatment now, so essentially at the same time as his TB and PCP prophylaxis is started? Should he start on antiretroviral therapy just as soon as he is tolerating his tuberculosis therapy and within 2 weeks of starting that TB therapy? Should we defer initiation of antiretroviral therapy until he has completed the first 2 months of his TB therapy? And recall that the TB therapy consists initially of 2 months of 4 drugs, and after that first 2 months, we reduce to just 2 drugs. Or should we defer initiation of antiretroviral therapy until after he completes the full course of 6 months of tuberculosis therapy? Now, until very recently, we actually did not know the answer to this question at all. But fortunately, the results of 3 randomized trials that were published in the New England Journal of Medicine just last year, 2011, have given us a lot of clarity regarding this question. And I'm going to step us through these studies one by one just to review the evidence so that we're comfortable with the conclusions. The first study was the Sabbat Trial. This was conducted among 642 HIV-infected adults with active TB in South Africa. These patients, each of whom had a CD4 count less than 500, were randomized to initiate antiretroviral therapy at one of 3 time intervals following initiation of tuberculosis therapy. For the TB therapy, patients took a typical tuberculosis regimen of 4 drugs for the first 2 months. This is known as the intensive phase of TB therapy, followed by 2 tuberculosis drugs for the subsequent 4 months, and this is known as the continuation phase of TB therapy. Now, there were 3 starting points for antiretroviral therapy for the HIV. 2 of these starting points occurred during the time at which patients were receiving their TB therapy. And these 2 groups were known collectively as the integrated therapy group. The early integrated therapy group started their treatment within 4 weeks of starting tuberculosis therapy, while the late integrated therapy group started their TB within 4 weeks of completing the initial 2 months of TB therapy. By contrast, the sequential therapy group deferred initiation of antiretroviral therapy completely until after tuberculosis therapy had been completed. It may help to show this visually on this chart. The arrows at the bottom will show you the 3 different points at which therapy was initiated. It may help to show this visually. It may help to show this visually as this current slide shows. So the 3 groups of patients starting therapy at different time points are represented on the bottom at these 3 arrows: the gray arrow, the red arrow, and the blue arrow. This gray arrow represents patients in the early integrated therapy group. These are patients who started therapy within 4 weeks of starting tuberculosis therapy. The red arrow is the late integrated therapy group. They start essentially within 8 to 12 weeks of starting TB therapy. So they wait until the first 2 months of 4-drug TB therapy has been completed, and then they start antiretroviral therapy. Whereas the sequential therapy group, here in blue, started their antiretroviral therapy only after all of the tuberculosis treatment had been completed. And so in this analysis, we are first going to compare how well did patients in the sequential therapy group perform in terms of mortality as compared with patients in both of the early and late integrated therapy groups. So I am showing the comparison of the integrated therapy group here versus the sequential therapy group here. The mortality curves by Kaplan-Meier analysis are shown here for the sequential therapy group and here for the integrated therapy group. And I think it's clear that there is a significant and substantial mortality benefit associated with starting antiretroviral therapy during the time of TB therapy as opposed to waiting until after TB therapy has concluded. This was a key finding of the Sabbat trial. Now remember, however, that actually within the integrated therapy group there were 2 different starting points. And so it may be useful to think about Was there a difference in mortality between those two groups of patients who each started antiretroviral therapy while receiving treatment for TB? In a subsequent publication, the investigators did just that. They compared how well did these patients fare who started therapy essentially immediately or within 4 weeks of starting TB therapy with those who deferred their antiretroviral therapy until after the first 2 months of TB therapy. And what they found actually depended upon what the initial CD4 count was of the patients involved. For those patients who had very low CD4 counts, less than 50, earlier therapy translated to a significant benefit in mortality as compared with later initiation of antiretroviral therapy. By contrast, those patients who had higher CD4 counts, no significant difference was observed in terms of mortality. So I think the lesson from this study was that the sooner antiretroviral therapy is started, the better. However, the benefit of this is most dramatically seen in patients with very low CD4 counts, for whom you really cannot afford to defer antiretroviral therapy more than a few weeks after starting TB therapy. Okay, the next trial was conducted in Cambodia. This was an open-label, randomized trial that compared clinical outcomes associated with initiation of antiretroviral therapy at 2 weeks versus 8 weeks following initiation of TB therapy for patients with HIV and confirmed TB disease. So a pretty similar design to the Sabbat trial. If you think about the two integrated therapy arms of the Sabbat trial, this is essentially what's being replicated here in the Camellia study, only involving patients in Cambodia. Also, all of these patients had CD4 counts less than 200. They received the same standard tuberculosis treatment regimen consisting of 2 months of 4 drugs followed by 4 months of 2 drugs. And these were the findings, which were broadly similar to what was seen in the Sabbat trial. Those patients who were randomized to start antiretroviral therapy earlier had a significant survival benefit as compared with those who started later, or 8 weeks after starting tuberculosis therapy. Lastly, the STRIDE study. This was, again, a randomized trial involving 800 patients from 4 continents. Most of the patients were actually from Africa, although patients from Asia, South America, and North America were also represented. All of these patients had confirmed or suspected TB. All had HIV disease with a CD4 count less than 250. Patients were randomized to either start antiretroviral therapy within 2 weeks of starting their tuberculosis therapy or 8 to 12 weeks after starting anti-TB therapy. So again, a very similar study design as we saw with the Camellia and with the at least the integrated therapy arms of the Sabbat study. In the overall analysis of this study, no significant difference in mortality was seen between those who started antiretroviral therapy earlier compared with those who started later. However, if you stratify the participants by initial CD4 count, we see the same effect that we saw in the Camellia and the Sabbat studies, namely that a low CD4 count did translate to a significant benefit of mortality associated with earlier initiation of antiretroviral therapy. In this particular figure, you want to look at comparing the blue line, which represents patients who started ART later and who had a baseline CD4 count less than 50, versus the red line, which represents patients who started antiretroviral therapy earlier and who also had a baseline CD4 count less than 50. So again, patients with very low CD4 counts had a significant survival benefit associated with earlier initiation of antiretroviral therapy. So returning to our question of when should antiretroviral therapy for HIV be started for this patient, recall that his CD4 count is now known to be 22. And so based on the results of the studies we've just reviewed, I think we would all agree that ideally he would want to start antiretroviral therapy as soon as possible. And the guidance from WHO and from others is essentially to start within 2 weeks. It's very reasonable to wait at least until the patient is clearly tolerating TB therapy. It's not advisable to start antiretroviral therapy and tuberculosis therapy simultaneously because there's simply too much overlapping drug toxicities. But if you can sequence them within 2 weeks, that would be the ideal approach for the co-infected patient with a very low CD4 count. For patients with CD4 counts higher than 50, the general guidance is you still want to start them on antiretroviral therapy sooner than later, but perhaps you have a little more time to make sure that they're tolerating tuberculosis therapy. Nevertheless, the guidance based on these recent studies is to start therapy within 2 to 8 weeks for patients with CD4 counts over 50. Now, some of you may be wondering, what about the risk of immune reconstitution inflammatory syndrome associated with starting antiretroviral therapy so soon in patients who have active tuberculosis? Indeed, it was the fear of patients developing severe iris that had led many experts to suggest that antiretroviral therapy be delayed after starting tuberculosis therapy, at least until we had the results of these clinical trials that told us otherwise. Now, interestingly, in the Camellia and Stride trials, they did see higher rates of immune reconstitution inflammatory syndrome in the early therapy arms as compared with those who started their antiretroviral therapy later. However, the mortality benefit of starting sooner more than offset the morbidity and mortality risk of iris associated with the early initiation of antiretroviral therapy. So let's return to our case. He is now tolerating tuberculosis therapy. He's on a standard regimen of isoniazid, rifampin, pyrazinamide, and ethambutol, and he feels prepared to initiate antiretroviral therapy. Which of the following statements is or are true concerning the initial antiretroviral therapy regimen? Do we need to avoid efavirenz due to drug-drug interactions with the rifampin in his regimen? Do we need to avoid nevirapine due to drug-drug interactions with rifampin? Do we need to avoid protease inhibitors due to drug-drug interactions with the rifampin? Or is rifampin such a problem that we are obliged to substitute rifabutin before we can safely start antiretroviral therapy? The correct answer is B and C. Indeed, there are significant drug-drug interactions between the rifamycin class of tuberculosis drugs and several of the agents that we use to treat HIV infection. Specifically, the protease inhibitors are the most problematic and are generally contraindicated for use with rifampin. Nevirapine also really should be avoided if possible. Efavirenz, it turns out, is okay. There is some suggestion that perhaps the dose of efavirenz should be increased slightly in the presence of rifampin. But nevertheless, efavirenz can be used. Raltegravir is another option that can be used. And the nucleoside reverse transcriptase inhibitors can generally be safely used with rifampin as well. Rifabutin is a drug that has fewer drug-drug interactions with antiretroviral agents. And so if you're in a situation where efavirenz cannot be used, then it may make sense to substitute rifabutin for rifampin so that you can use protease inhibitors in the antiretroviral regimen. I would suggest, in cases like these, consulting with your pharmacist, consulting with drug interaction tables that are available online. This is a table that we use in the clinic where I work. It can be found at the website madisonclinic.org. And it simply lists what the key interactions are between the HIV medications and the key tuberculosis regimen. And as you can imagine, it goes on for a couple of pages because there are so many considerations that need to be taken into account. Thank you.